Dear colleagues, thank you for having invited me in participating to this event. It's really a pity for me not to be able to be present in person, but it's important, and I want to witness my presence delivering my recorded lecture. And the topic I will read about today is on organizational safety in anesthesia. As you can see, I choose as an image to represent which should be the role of doctors and especially preoperative medicine. The image of San Rocco healing the plague that is represented from Tintoretto in the mid of the 16th century. It's important to remind how medical error, especially in the preoperative and the hospital-based care, is a relevant proportion of the possible causes of death. And probably we all have seen in the clinical practice around us some examples of unintended act or inability to achieve the intended outcome or failure to plan appropriately an action to be completed as intended. All of these are clear examples of medical errors. And more in detail, it's important to remind how postoperative deaths represent a major burden in the possible causes of death, representing the third leading causes in hospitalized patients. What is even more interesting, as reported in the survey published in 2012 in the Lancet, out of more than 40,000 patients, expect the actual mortality was about 4% before hospital discharge. And this is far beyond the expected rate. But more interesting, it is notable that the death rate ranged from 0.45 to 15% between Finland and Poland, with an average 6.7% in the central core countries. Studies run in more than 300,000 patients at the Albert Einstein University in New York throughout a decade of recording the clinical practice in a single center study showed how more than 90% of adverse outcome in anesthesia practice should be considered system failure instead of individual misconduct or failure. And another relevant aspect in this field is to notice how the high levels of mortality in patients undergoing cancer surgery in low and medium income countries cannot be fully explained by the late presentation of the cases, but the whole preoperative period management might represent a substantial proportion of death causes. More recently, in January 2022, has been published in European Journal of Anesthesiologists that report from more than 80,000 cases from a single an insurance database in Germany, and about 50 patients died in the preoperative period, and 30 of these deaths were attributed to anesthesia management. Of note, according to the author's analysis, more than 85% of these deaths could be considered potentially avoidable. And especially interesting is that 40% of these deaths were related to airway management, 20% monitoring, but more than 50% of the causes was attributed to suboptimal communication and human factors. So there is ample room to improve the way and the safety level of our discipline. In an editorial and review paper published in 2010 in British Journal of Anesthesia, Toff identified 4 relevant aspects of organizational anesthesia that can be also found in civil aviation. And these are training and simulation, the use of standard operating procedures as debriefing and communication, the relevance of human factors and the ergonomics as the use of checklists and situational awareness, and last but not least, the importance of safety management system and the role of resilience. We will go through each of these components, and we will review how these elements can be implemented in the clinical practice. Training and simulation. It is important to notice how there is a huge variability in the training course and certification requirements throughout Europe. And the use of simulation-based training, despite potentially relevant, is not yet based on established criteria to certify the competencies acquired with this approach. And is also notable how the training program is now shifting from the traditional model to a competency-based medical education that is extremely difficult to certify. Second point, the use of standard operating procedures as the briefing and communication. As we mentioned above, communication is an extremely relevant proportion of our practice and the risk for possible errors. And we should also remember how professionalism, that is the respect and honoring of our specialty, is a key component of the quality of delivered care. We are not only acting for ourselves, but for the entire specialty and group of colleagues we are working with. This is a relevant study, especially because it presented a negative result. The authors have tested the use of a video-based educational program to increase the communication competences among residents, but they recorded that this approach, even if highlighted the importance of this element, has not successfully improved the quality of communication. So specific programs need to be designed, and we should become more and more aware of the importance of this part of non-technical skills into our clinical practice. Especially important is to develop and underline the attitude to learn from actual critical events. And this should lead to radically change the current culture that should be shifted from the traditional blaming approach into a more understanding approach where the causes and the necessary action to avoid future critical events that include failure or near miss can be avoided or prevented. What should change is the traditional ABCD approach that is often seen in many centers and for many of the colleagues that have leading position that appear, blame, criticize, and disappear, living the reality as it was before. So there are several hints that can participate and contribute to increase and promote a better communicational behavior. It is important to be aware of the role of nonverbal communication. It is important to identify how communication should occupy a specific and dedicated role in the clinical practice. And there are also specific hints on the way an effective communication can be run, including to avoid negative turns and rather use a positive and more compassionate approach. So normalizing communication in the hospital teams is really one of the major priorities to prevent and minimize possible errors. And it should be clear that when we think about communication, this is the interpersonal communication at the workplace. So it's not intended for personal reason, and it should be addressed to put at the center the interest of the patient. Human factors and ergonomics, how these elements might contribute to increase preoperative safety, and in particular, the role of checklist and situational awareness. Checklist has been proven to participate and to increase the safety in the preoperative mechanism. Unfortunately, it is not easy to talk about medical errors and to reason and accept the possible room for improvement. And larger part of this is due to medical narcissism. It should become clear that we should change our attitude to improve the practice. Here you see how different is the implementation of preoperative checklists in the different countries. It is also important to remember that the use of checklists is not necessarily associated with better care. This is how checklist is important. We know that the use of World Health Organization surgical safety checklist reduced overall complications from 11 to 7%, and also mortality was reduced by 50%. So it is important to implement in due time the use of this device. Situational awareness is another relevant aspect of our clinical practice. This is responsible for a substantial proportion of misunderstanding or inadequate decision. We should practice and become aware how this task is among the most relevant non-technical skills of our profession. And there are appropriate process to familiarize and to include a dedicated training in our specialty. And it's important to understand how the lack of situational awareness is a major determinant of failure or near miss in a large proportion of cases, being responsible for approximately 80% of complications. So we are all aware how there might be a distance between the work as imagined and the work as done, but being aware of this is important to make these two realities, work as done and work as imagined, the closer possible. The resilience. Resilience is the ability to adapt to the changing environment. And this is a major characteristics of the everyday practice in the operating room. So we all know is it the desirable characteristics, but we also think that is not fulfilled as a duty in the largest majority of our departments. And we know how resilience should be based on responding, monitoring, participating, and learning, but to practice each of the individual components is not always easy. To implement and improve resilience in anesthesia and intensive care, these are some of the hints we can learn from the military environment. It is important to know that complexity is a major component to increase overall resilience of the system. So non-technical medical errors are a prevalent component of our practice. As it happens in successful organization, we should rather address what is needed to fix the potential for or the actual failure of the system, rather than understanding who should be blamed. And I want to cite this sentence from the philosopher of science, Karl Popper: true ignorance is not absence of knowledge, but refusal to acquire it. It seems to be, to some extent, our case. In conclusion, safety in anesthesia and preoperative medicine is substantially improved, but there is much room for further improvement. The largest proportion of deadly intraoperative complications are potentially avoidable. Several features can be extracted by aviation and implemented in clinical practice. High quality of training, standard operating procedures, systematic pre and post debriefing, safety management with resilience attitude. Thank you for your attention.
Большое спасибо. Уважаемые коллеги, у нас профессор Билотта на связи в онлайн-режиме, поэтому есть... Нет? Хорошо. Ну, если есть вопросы, у нас профессор, я так понимаю, может быть, после второго доклада, да, подключится? А, нет, есть сейчас. Поэтому, если есть вопросы, пожалуйста, задавайте. Да. Микрофон есть.
Dear Federico, thank you for your lecture. And probably my question is, how do you think, how long can be the period of adaptation to all these things which are rather stupid for the first look? I mean, standard operational procedures and all these not brightly interesting things which are completely necessary for the safety of our patients. Я спросил профессора, как он думает, насколько длинным может быть период адаптации к этим скучным и ужасно неинтересным стандартным операционным процедурам, которые тем не менее необходимы. How do you think?
Thank you, Konstantin. I hope that the lecture was not as boring as the topic, and I hope that my answer will address your questions in an appropriate manner.
Спасибо, Константин Михайлович. Я надеюсь, что моя лекция была не такой скучной, как сам ее предмет, о котором мы только что говорили, и постараюсь ответить на вопросы.
The point is that we wish to... Okay, in civil aviation, nowadays, the risk of major failure, that is a system damage that eventually associate with casualty, impact one passenger every 300,000.
Вот как пример, в современной гражданской авиации риск каких-либо технических проблем с жертвами, да, составляет один пассажир на 300 тысяч полетов.
In anesthesia, deadly complications in the immediate preoperative period happen in 1 out of 3,000 to 5,000, depending on the type of patient and context patient.
В современной анестезиологии осложнения с летальным исходом происходят в одном случае на 3-5 тысяч случаев анестезии.
And this is pretty consistent in the world.
И эти показатели мы видим достаточно системно везде в мире.
So we understand that dimensionally there is a difference in treating the priorities. And we, as anesthesia, do have the potential for much large improvement.
И, конечно, здесь вопрос выбора приоритетов, насколько мы видим. И нам, как специалистам, анестезиологам, реаниматологам, в отношении безопасности есть еще много над чем работать.
The point is that in general, we consider it acceptable, of course not desirable, but acceptable, should a complication occur, because we treat with the people that comes with a disease, with patients.
Мы работаем с пациентами, с людьми с заболеваниями, и поэтому в нашей среде считается, что осложнения допустимы. Конечно, мы не хотим, чтобы они развивались, но они допустимы, приемлемы.
Желательны, но приемлемы.
Thank you. And sometimes we know that individually we did our best.
И мы понимаем, что на индивидуальном уровне мы, как врачи, анестезиологи, реаниматологи, делаем все, что мы можем на максимально высоком уровне.
But in civil aviation, what is going on since more than 4 decades is that the pilot is an extension of the system, and the priority is not on the pilot, like on the doctor, but is on the system itself. So every failure that is not only a deadly event, but every dysfunction of the process is analyzed in order to prevent the same event in the future.
Но если мы посмотрим на опыт гражданской авиации, то мы видим, что пилот работает не на индивидуальном уровне, а это часть общей системы, системы безопасности. И каждый вот такой случай, связанный с летальным исходом пациента, его нужно анализировать для того, чтобы предотвратить такие же ситуации в будущем.
So you see, certainly, Konstantin, it will take long time before we reach that level.
Конечно же, у нас займет большое время для того, чтобы достичь такого же уровня организации системы, как в гражданской авиации.
But the first change is to understand that things should not be analyzed in the manner of attributing the responsibility to one of us, to the doctor in charge, but rather to design a system that is better performative.
Но очень важно на первом этапе понять, что не нужно винить во всем конкретного врача, отдельного человека, а нужно работать с системой для того, чтобы предотвращать развитие подобных ошибок в будущем.
So to conclude my reply, what we know, and we call it a clinical experience, the one that an elderly person like me has developed over 30 years of career, should rather become a community or system experience and not go away when I'm going to retire.
И вот как пример, как заключение того, что я сказал, вот я врач с более чем 30-летним опытом, у меня есть мой клинический опыт. И наша задача заключается в том, чтобы этот клинический опыт был передан, был внедрен, интегрирован в систему. и чтобы он не исчез с моим уходом.
I hope this was clear.
Я надеюсь, ответ был понятен.
Dear Federico, thank you very much for your reply. And я хотел бы для нашей аудитории выделить вот этот момент. Наверное, это действительно очень важно. Вот смотрите, разные исторические эпохи сменяют друг друга. В одну эпоху мы ясно понимаем, что важно понимание причин, то, о чем он говорит, причин. Почему это произошло и как сделать так, чтобы это не произошло никогда больше. В другую историческую эпоху превалирует поиск виновника, да? Но как это у нас бывает, да? Упал метеорит, Следственный комитет возбудил уголовное дело, самое главное. Это главное действие, которое завершает у нас почти любое сообщение о любой неприятности в последние годы. То есть эпоха должна сдвинуться все-таки к тому, чтобы в интересах безопасности поиск причины доминировал. Не поиск виновника, а поиск причины, потому что причина часто носит системный характер. I've noted to our audience in Russian that it's very important really to find a cause, to find a reason for some adverse event, not guilty person, but to find a reason. Thank you very much for this very, very important note. Thank you, Federico. And
My pleasure.
we should to go to the next lecture. Thank you very much.